I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Fridays with Faisel. We're here because everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is a culture of prevention. Robert, how are you doing?
I'm doing well, Faisel. Excited to be here once again.
Great to have another topic. I think right now, like more than ever, as I'm reading about the number of cases in the country, like that we crossed now 140,000 cases of COVID. Is that what we're at right now?
Yeah, I think they're expecting it to 150,000 a day this weekend. I think we're going to hit that number.
Goodness. Well, I'd love for you to get your graphics up.
Yeah, there it goes. Yeah. Well, I think this is going to set the stage for today, and I know the folks at ChenMed are the absolute masters of sort of prevention and early intervention and sort of making sure that you are addressing those high value services up front. And the quote from Benjamin Franklin, "An ounce of prevention is worth a pound of cure," is what I think will sort of underlie all of our conversations today. It's better to prevent something in the beginning than to have to deal with the ramifications at the end of the day. And from a cost perspective, if you're able to prevent something from happening downstream by using a low cost, high value intervention upstream, then you save money and you save patient suffering, which is most important. So I think that I'm excited to talk about this today. And we have some really great guests. We have a great guest today. So Faisel, why don't you introduce our guest, and we'll take it from there.
Yes, I'm so pleased to introduce Dr. Elizabeth Vilches-Olivera. Hi, Dr. Vilches.
Hi, Dr. Syed. How are you?
I'm doing great. Thank you so much for taking time out of your clinic. I know you're very busy. She's one of our associate chief medical officers. So to take time of her busy day, all of our physician leaders still have time in the clinic. So just to take time out of her busy schedule to come join us over lunch today. Thank you so much.
No, thank you for having me. Super excited to be here.
Wonderful. And we have Dr. Dan. Dr. Dan, welcome back. Good to see you again.
Thanks, Faisel. Looking forward to being here with you today and hopefully having some good questions from the audience today.
We just moved. We just moved 2 days ago after a 5-month-long renovation. And one of the workers here at the house told me that he takes Tylenol daily for headaches. And he's been doing this for not weeks or months. He's been doing this for years as part of his normal routine, where he takes a couple Tylenol and he just gets on with his day. And I asked him, I said, what's causing the headache? And he said, he doesn't speak English. He speaks Spanish. He said, no sé. He's like, I don't know. He's like, I just take the Tylenol and I just move on with my day. And, I'm so busy. And I think about like how much that applies to so many of us, right? That we'll just take whatever we got to take. We have a culture of taking pills or just doing whatever we got to do just to make us functional, rather than to dig in a little bit to see, well, what was causing the headaches in the first place, to avoid having them, to avoid having to take the Tylenol.
Absolutely. That's just a pill for this and a pill for that, and never really getting to the upstream to the beginning of the problem makes it very difficult.
Absolutely. And I think that's when having a good primary care physician kicks in, because it happens in my culture, right? So as Hispanics, we tend, oh, we cannot be dysfunctional. We have to work. So there is no time for getting sick. There is no time for going to a doctor. There is no time for anything. So it's just really changing that mindset in, especially in the population that needs us the most. Listen, you don't have to feel sick. You don't have to be taking a pill every day. Just come and see me. And I do this with my patients. Come see me. Let's figure out what's going on. I think here at Chen, we call ourselves pride in primary care, right? And the reason behind that is that when I see my patient, I just don't see a number. I don't see just a disease. I see my patient. So my focus when I meet them for the first time is like, listen, I'm here to prevent disease. I'm not
Mhm.
here to treat a disease. I want to treat you. I want to prevent you from suffering one. So how do we
Mhm.
do that? Well, we got to do labs. I got to see you frequently. I want to see you, talk to you, meet your family, get to know where you live and how you live, because that's the only way I can help you be better. And I give them my cell phone number, and they're like, I call that the wow factor. Aside from doing a thorough physical exam, is like, you're giving me your cell phone number? I'm like, yes. I want you to have access to me 24/7. Mind you, they know my kids, they know my husband, they've talked to my husband, and it's like they are part of my family.
Mhm.
And I talk to their kids and they're like, I have never seen anything like this. I'm like, come to Chen and you'll see it not just in me, but in every PCP that you meet. And you see the quality of life. When I first joined Chen, I took over a panel and I started growing my panel. And that first year, my patients were going to the hospital. My patients were turning very sick. Now it's really difficult for my patients to go to the hospital. Like I haven't seen a patient of mine unless they're really, really towards the end or they have a disease that I have as out of my controls for them to end up in the hospital. And it's all that culture of prevention,
Mhm.
right? When you really focus on preventing, the impact you have in the quality of life of your patients is wow. That's the wow factor there.
Right.
Do you
And
think?
I think, go ahead, Faisal.
So I was thinking, do you think that that's why, as a country, at the end of the flu season, we can't crack that 50% flu vaccination rate amongst American adults?
Absolutely. I mean, I gotta tell you, I'm a strong believer on the flu vaccine. When I first started practicing as a physician, even in my own family, people would not believe in the flu vaccine. And I told them one day, tell me the reason. Tell me the reason why don't you believe in the flu vaccine? Do you know they didn't know how many people would die from the flu vaccine. They didn't know the reason why. I mean, from the actual flu, correct myself. They didn't even know what was the reason for the flu to kill them. So I'm like, do you know that you're giving away the one chance you have to prevent you from getting the flu? You're actually saying no to something that can save your life. It's all education, communication. My patients, initially, they wouldn't get the flu vaccine. Now ask them. I don't even have to tell them. They come in September, like, where's my flu vaccine? They'll get it. So it's education and that communication with your doctor and your patient. And it's not just having communication, it's having a relationship with your patients and your
Mhm.
patients having a relationship with you. I always tell them this is like a marriage. We got to talk and we got to trust each other. Otherwise, this
Mhm.
can't work. So I'm doing for you what I would do for my parents. And you're getting this because this is going to save your life. If we do this in America with every citizen in the United States of America, I can
Oh,
assure you 90%, let me not say 100, 90% of the population will get the flu vaccine.
Wow. And what I'm hearing from what you're saying is it's important to look at people holistically, not just as a set of lab values. And when we think about prevention, I think from a conceptual level, can we bring up the factors diagram?
Um, let me holistically. So
Yeah.
let me put this
So
in. Yeah, go
so
ahead.
here is sort of all the factors that we know impact health. And so in order to be able to address this with your patients, you have to get to know them. You have to learn about their homes. You have to learn about their behaviors. You have to learn about their environment. You
right.
have to be able to address and work with people across this whole circle. It's not just healthcare services, which are lab tests and the pathophysiology, as Faisal likes to say. It's being able to address a lot of these areas. And part of that comes from public investment in social services and in housing and in poverty programs and in education. So a lot of this is out of the hands of your typical physician, but a lot of it can actually be addressed. And I think that you guys at ChenMed really do a great job with that. And you do spend the time with your patients, you see them more often, and you can make those healthcare services, which are really typically only 20% of affecting health outcomes, you can expand that because you can address these individual behavior factors and some of the social economic factors. So this is what, when we think about prevention, it's addressing all the factors that fall into these categories and trying to improve health because of that. So that's what I'm hearing from what you're both saying, and I know this about what you do at ChenMed. You do, address health holistically, and I love that. I think that's great, and that's where we need to get the rest of the country going to. And it's part of the culture you guys have established at ChenMed, which is we care about this. We are going to view people holistically, and we're going to spend time with our patients to get to know them inside and out, so that we can help work with them to be preventive. Is that correct?
That is correct. That is very much correct. I think that factor diagram that you just showed me, it's the whole patient, right? So it's basically, I'm looking at a person and all those things factor in. It's not just what you're seeing, it's what's underneath those multiple skin barriers, as I call them. It's such an impact when you get to know them to the level of, again, knowing what is it that they lack, what is it that they have, who's there to support them and who's not, what are the things that are really moving this patient to be sick or to feel sick, emotional state. Sometimes physicians don't tend to see the emotions of your patient. I mean, by seeing them frequently, I can tell when my patient is sad. I can tell when my patient is happy, or when they're stressed out and I ask them, "You're not yourself. Can you tell me what's going on?" And they're like, "How do you know?" I'm like, "Trust me, it's not a crystal ball. I know you." And it's because of the model that we have. I see patients sometimes every day if I need to. I don't, I mean, this was my first job out of residency, but I did have my outpatient clinic in a fit for service world. And I would see patients once every year. Did I know them? No, I couldn't. Yeah, I mean, I did not have the impact that I'm having now. And when I think about medicine, when I first took on medicine as a career, I always thought I want to be that, like my pediatrician. She will go to my house to see me. I've gone to my patient's house to see them. Do you have any idea how much that touches them? And that also engages them in their care. So, I mean, let Dr. Syed talk for a little.
Well, yeah, no, I remember one of the first conversations that I had with Robert about telemedicine, and how, remember, we started in March, we made the switch in less than a week. We went from this high touch in-person model to completely telephonic, like it was almost 100% telephonic. And then soon thereafter, the telemedicine with the video calls and all. And I remember telling Robert, I was so shocked to find how intimate the phone calls were on video, because the patients were not like my patient, like all our patients are in their 70s on average, between 72, 74 years old. And I found that many of them don't even FaceTime their children. They'll FaceTime their grandchildren, and so then to have their doctor, who they already feel very comfortable with, now being able to show them, showing the doctor, hey, this is what I have in my fridge right now. This is where I'm sleeping. This is what I'm living with. This is the noise I have to hear from the neighbor across the street. This is why I can't sleep at night. It gave me a perspective that was much, much, much more intimate even than the doctor-patient relationship that we have in the center. Because then when they have to come to the center, there's a process of coming to the center. You come to the waiting room, you got to check in, you go through you get your height and weight and all that stuff done, you get the screenings, until you're finally set up in the room waiting to see the doctor. So patients are kind of more, they're ready to see the doctor. They went through this whole process to see the doctor. And with telemedicine and with just telehealth in general, all those formalities go out the window. It's a much more intimate.
And Faisel, I love it when you tell that story. I've actually included it in my next book because I think it's just extremely impactful. And so I have a whole section on you talking about that. And that's also what we do at my company, Avenues. So we try to help fee-for-service providers implement these higher touch models of care using virtual care services. So we train our nurses in this case in motivational interviewing, and they do audiovisual telehealth visits with patients in conjunction with fee-for-service physicians, because not everybody is a ChenMed, not everybody is so advanced, and so our goal at our company is also to help get those higher touch models where we can get to know patients, where we can try and be more preventive as well, using just a solely virtual model. And so that's what we do, and I think we're very much alike in those approaches. So I love that we both see the value of those virtual care models to actually get into the home with the patient, get to know them a little bit better, and see it as a tool in addition to getting to know the patient in person. So I'm curious, in terms of at ChenMed, I know we've talked about this before. What do you do when you hire new physicians to get them into this culture of prevention? They were trained in fee-for-service, they were trained in sort of the older ways. How do you get them into this mindset?
Well, I can get started, and Dr. Dan and Dr. Vilches can jump in because it's great. When I meet a new doctor who just has just embraced the full risk model and is learning about how to manage this very complex patient population with very limited resources, I tell them that every single one of us were trained to respond to a chief complaint. Mm-hmm. And all the documentation in fee-for-service is based on this chief complaint. You have a chief complaint, and then you get the history, and you go. But if their chief complaint at that particular moment of their lives is by the doctor addressing their chief complaint, if it's not having an impact to the overall health of this patient, there's always this disconnect. Like, okay, this might be your chief complaint, but let me tell you my primary concern as your doctor. Yeah. Mm-hmm. So one of the first steps we do in our orientation, our onboarding process is quite extensive. It's 3 weeks. 3 weeks of just orientation and training, really learning about how to think like this preventive health coach. Mm-hmm. And it's really unlearning a lot of what we learned in medical school and in residency. So one of the lines that I like to tell all the doctors is, okay, you tell the patient, I understand that this is your chief complaint, and we will address this, but now let me tell you what my primary concern is, especially if you have a COPD patient who's in between COPD exacerbations with low back pain as a chief complaint. We'll address this. I will address your low back pain as your chief complaint, but let me tell you my primary concern about trying to prevent this next COPD exacerbation.
Right.
Faisel, we have a question here from Chris that sort of fits in with the new doctor onboarding, and he says he's a strong believer in our model. How often are your patients and are their caregivers reaching out on the evenings and weekends? And I know a number of the new doctors, when we start telling them we want them to give out their cell phone number, they think, what am I getting myself into? So we'd love to hear what Dr. Vilches has to say about that.
Absolutely. Okay. And let me tell you, I have right now about 300 patients, and they all have my cell phone number. At first, I thought they are going to call me every single day. Oh, my goodness, they don't. As a matter of fact, at the beginning, when they will end up in the hospital, I will be like, why did you not call me? I didn't want to bother you. No, now I'm upset. The fact that you didn't call me, even if it's at 3 o'clock in the morning, why did I give you my cell phone number? If I give it to you, I want you to call me. I'm going to be happy if you do. I'm happy if you reach out. But trust me, they do not abuse that. They do not abuse the blessing of having direct access to you. On the contrary, they respect your time with your family, with your husband. They actually, they apologize to my husband when they call me at 3 in the morning. Like, can I talk to your husband and apologize? I'm like, no need. He's used to this. So he knows that you're family. So we need to treat you like family, and we're going to treat you like family. And I give this feedback to the new PCPs. I'm like, don't be afraid. It's not going to be bad. I can assure you. Because these patients, they're so humble. and they're so appreciative of everything that you do and every single minute that you spend with them, that they're going to be respectful of your time. And when they call you, you know that they're in trouble. You know that they're going to have some insecurities. As minimal as those insecurities are, as minimal as that question is, it's going to have such an impact on their trust for you and on their healthcare, on how they manage their anxieties. So
Mhm.
it's it's a blessing, the fact that I can give my cell phone to them, not just to them, but to me. The fact that I know that they trust me and that just one, everything is going to be okay, can change their lives, can change the way they're viewing their problem at that specific moment. Just
Mhm.
follow my lead, take deep breaths. We're going to take care of you. That's all it takes. And you know how many times I have avoided that patient from ending up in the hospital, from ending up in an ER visit, and the family so thankful. Thank you, doctor, for being there for us. Like, it, the impact is tremendous, and I wish every PCP would see it that way. Like, it's such a small thing, but it has such a huge impact.
Huge
Mhm.
impact. I mean, the patients, when they know that the doctor is giving their cell phone number, I mean, just that act alone. So but it's also a series of things. It's the entire situation. The patients know they get a text message every day from the center. They get a phone call once a week from one of our staff. They're
Mhm.
used to seeing their doctors. Actually, we should probably come up with the top 3 reasons patients don't call us. I would say the number one reason that used to really frustrate me was when the patients would say, "Well, I knew I'd be seeing you in a week or two because they're used to seeing us every month." And I said, "Why didn't you tell me sooner? I could have gotten started on something for you sooner." And then, "Well, I'll see you back in a couple of weeks." I think that would be the number one reason. And then number two reason, especially if it's over the weekend, would be, "Oh, I know that you're probably busy with your children. I didn't want to disturb." And it kind of goes back to number one. I knew I'd be seeing you back again in a week or so. Like I figured it was something that could wait. But that's what it is. You see, when the trust, you see, it's coming down to the trust. See, the fee for service world, the trust is not there. People are desperately looking
Mhm.
for solutions. Let's go back to the headache example. That, okay, I've been having headache now daily for the last couple months. Oh my God, it's got to be something awful. It's got to be cancer, something like that, some kind of tumor in my brain or something like that. And so they're in desperation for things like a headache, going to the emergency room, which is advertising. Hey, 5-minute wait time, 10-minute wait time, and they'll get this unbelievable
Mhm.
workup done. By the way, I just read that 1 out of 3 people over the age of 65 who step foot into the emergency room will get a CAT scan. Doesn't matter what like 1 out of 3 people over the age of 65, as soon as they step foot into the emergency room, get a CAT scan.
Wow.
But it's sort of along those lines. If the patients can't trust us with the little things, right? We create this environment where they can trust us with the little things.
Mhm.
That's how you get people to trust you with the big things. You can't
Right.
expect anyone to trust you with any of the big stuff if they don't feel like what Dr. Vilches said earlier today, that her patient, she didn't have to wait for the patient to tell her that there was something wrong. She started that conversation with the patient, saying that, hey, something's off here, something's not right. When you
Right.
have that kind of relationship, it's like a marriage. And
Yeah.
a good marriage is, the one partner doesn't wait for the other one to complain about a problem. You know there's something wrong even without any words being spoken. And that's sort of the way it's like with a good doctor-patient relationship.
Right. And in fee for service, everything's transactional. So you don't have the time to spend because you need to meet your certain, patient volume requirements. And it's just not the same sort of like culture where you can build those relationships and actually, have a human connection there rather than, a business or a transactional service connection, if you will. And what you've said that I really like, and can we bring up the next diagram? This is one of my favorite diagrams in the whole world when I talk about sort of interventions that are of high value. So what we have on sort of the y-axis here, it's cost of a particular intervention. And then what we have on the x-axis is effectiveness. And you're giving out your cell phone number to your patients. That falls into the definitely a best buy category, which is high effectiveness, low cost. And so what I've seen from the folks at ChenMed, having talked to you guys in your model, is you guys are masters at the definitely a Best Buy area. You do a lot of things like flu shots and building relationships and giving out your cell phone numbers that are very inexpensive but very effective at preventing other costly episodes down the road. And you use motivational interviewing, which is perhaps a little bit higher cost because you have to spend time with the patient, but it's also very effective. And so finding things that fall into that D square down there is very important for healthcare moving forward, particularly under full risk models. And a lot of healthcare, CAT scans, for every patient that comes into an emergency department is a low effectiveness, high cost, wasted by. And so finding these different tools that are preventive are often very, very effective and low cost. So under the Affordable Care Act, they established the U.S. Preventive Services Task Force, which they do a lot of evidence reviews of interventions that do fit into the low cost, high effectiveness category. And they mandate those as being covered by insurance across the country. Those are things like flu shots, like depression screenings, things that have high value that actually produce benefit and are prevented for patients down the road. Things like mammograms, a lot of screenings, obviously, and then a lot of vaccinations are included because those are high value services. And so this is what I like to use when I say, should you do this, healthcare organization? Let's look at this chart and let's say, okay, should you do this? Is it going to provide value for patients? And does it fall somewhere within a reasonable cost? And unfortunately, healthcare as a whole falls into the definitely a wasted by category in a lot of times. And it's all about getting back into the definitely a best buy category. And I know you guys at ChenMed in particular are very, very good at that. And this is something that I think is really important for people to take to heart when we think about hearing the words like value-based payment, value-based care. It's about finding those things that produce the most value and prevention for patients. And it starts with a culture of looking for that. If you're just focused on operating your organization the way things have always been done, you're not going to be able to look for those things. So the culture you've established and training people to come into this where you care about that is the first step to starting to identify things. So we can get rid of it now. I just love that diagram.
Yeah, Robert, I actually have I'm going to ask a question this week. One of my own questions is, so preventive services have the most bang for the buck. You're talking about the U.S. Preventive Services Task Force. So like when you do the first mammogram or the first colonoscopy, that always gives you the most bang for the buck. Mm-hmm. But we have problems in our society. The well-insured people wind up getting too many. They get mammograms more frequently than are recommended. They get colonoscopies more frequently than are recommended, while the neediest patients don't have access to the first ones, which would really provide us the most benefit in years of life saved overall as a population. And I guess I would like your ideas. How can we as a society deal with this?
Yeah, and I think this goes back, if we can pull up the factors chart that I use when I do book talks. This is a great question, Dr. Dan. There's twofold approach to this that I see. One is you have to have congressional or state level legislative action that encourages these types of activities and provides coverage to people who don't currently have that. So that's the public investment piece. Those are things like investing in health education, public health services, and ensuring coverage for social services for people who are sort of in that category of not being able to afford a lot of these services. And that often, just like the ChenMed population, are the high cost people in the country anyways, because they're not receiving these high value services. So it comes sort of at a legislative high level society decision to invest in this. But just like you're doing at ChenMed, healthcare service organizations can also do a really good job with this as well by rethinking the way they deliver healthcare. And Dr. Dan, to go back to the ACA, the goal of the ACA was to extend coverage to 100% of the population. I think it got very close there. And then the idea was with the U.S. Preventive Services Task Force, if they rated something as an A or B rating, everybody who had coverage would get those services covered at no cost to the individual. Unfortunately, it didn't roll out the way that it was intended. A lot of people still fell into a lack of coverage or a coverage gap, and then they were unable to access those services in the first place. And that's something that I think is really, really important, is that the people that need these services most, that can get the most benefit from them, often don't have access to them. And that's something, if we want to, as a society, if we want to actually improve the health overall of the country, we have to deal with those inequities. We have to ensure people have coverage to these low-cost, high-value services. That's just going to improve health for everybody. And I think that your focus at ChenMed is obviously on that group of people, and it's the full risk model is allowing that to happen in a lot of circumstances. But there's still a lot of work to be done with people who are uninsured.
Right.
Yeah, we
and
believe that. Oh, sorry.
Go ahead. I was going to say the other issue is the length of time you have somebody insured as well. I mean, the insurance company, you would think that all employers would want to pay for all this preventive care, but it takes, according to Kaiser, it takes about 5 years before paying for all of this preventive care starts paying off. And so if an employer has an average length of time on the insurance policy of less than 5 years, they're not really interested in paying for the preventive care.
Right.
And so that's the other issue, is some of this stuff needs to be done, as you pointed out, at the society level, not at the individual policy writer or policy holder level.
Yeah, you're totally right there, Dr. Dan. I mean, the situation is that there's a lot of churn with insurance coverage, and one payer who might have somebody for a year doesn't really have the incentive to invest in that person's health for the long term, because they might go to another insurer. Now, perhaps if everybody did it, even if there's churn, we might get a healthier population altogether. But that way of thinking, that culture of prevention, is not as pervasive in healthcare as in this group and as we'd like to see. So thinking longitudinally down the road, to be able to say this works here, this provides a good outcome later, is tough to operationalize in the current system. So I do think that it is a societal level change that we need to make to be able to ensure that coverage and that culture of prevention is something we really emphasize. And other countries have done it better. They have lower healthcare costs. They emphasize primary care more. They emphasize coverage and access to that primary care, and they have a healthier population overall because of it. Our inequities make us a whole lot less healthy as a whole. And that's something that, again, needs investment from a high level. Although organizations like ChenMed are doing their dead level best to actually make that happen for their patients right now.
Yeah, you bring up something really great with that last point, Dr. Dan. I think about, like, in places like the Dominican Republic or India or Pakistan or anywhere else really in the world, where people, the general public, are afraid of getting sick because of limited places to go to get an intervention. And it's like you have in America, gosh, in Tampa, we probably have 30 hospitals within like a 15-mile radius. No kidding. And with all these different services offered at each one of these places, so people do start getting kind of relaxed, especially if you have the means to be relaxed, to think that, well, if something happens, I know so-and-so's had so many stents placed with, I know so-and-so's had this thing done with their, that we also start getting relaxed, thinking that, well, I've got all these options. Whereas in other places, they're more fearful or concerned about having to get into this system that may not be adequate to respond to them properly.
Yeah, and in the U.S., I mean, we have the best healthcare in the world next to some of the worst cared for populations in the country. I mean, if you think about, like, let's take Johns Hopkins, for example, in Baltimore, right? I mean, you have a premier worldwide healthcare organization, and you have a city population of people that might not even have access to primary care, and so we spend so much money on this incredible, like, innovations and incredible biotechnologies to get even more precise with genetic interventions and genetic therapeutics. But at the end of the day, we don't even get the basics right in the U.S. We have excellent healthcare services. We just don't give people access to them. We don't emphasize the high value ones. And that's where our problems exist here. That's why our country is less healthy than other countries. There's a lot of factors that go into it, but at the end of the day, we don't do a good job of addressing these the factors that affect health, like individual behaviors and the social determinants that impact people's ability to do stuff. Yeah.
because we're too reactive. We're too reactive as a society. Like we are a culture of just being reactive rather than being proactive about the most important thing in any of our lives outside of time. Probably time is our most valuable thing that we have in our lives, but our health, our
Right.
health, and then especially for those in society who may not understand as well as others. When you're going into these underserved communities where there's a culture of just trying to survive,
Mhm.
trying to talk with someone who's trying to survive about something like the importance of education. Talk with me about, okay, so you want me to spend this much time on education when I'm just trying to survive, or
Yeah.
trying to explain to someone the importance of coming in to get a well visit
Mhm.
when the entire process to come get that well visit, especially if you're relying on public transportation, like
Mhm.
in Tampa, a 15, 20-minute car drive can easily take over 2 hours in public transportation.
Right.
So to come for a quick well visit, the time that's required for them to take out of their busy days, just when they're in survival mode.
Right.
And Dr. Dan, we were just talking about recently that like somewhere like half of America earns less than $20 an hour or something along those lines. When you're living in that state of mind, you're in survival mode. You're going to push
Right.
through whatever you got to push through so that you can provide for yourself or provide for your family.
Right. Right. And I think what I'm curious to hear from you, Dr. Vilches, is what can you give me a couple practical things that you see in your day-to-day work that you do to fix some of these issues or to encourage prevention with your patients? I think we like to talk both conceptually here at Fridays with Faisel, but we also want to make sure that we make things useful. So what do you have that are like really good tips for people when they want to build this culture?
Absolutely. Well, COVID has definitely come with a set of challenges that we didn't have before. So, but it has taught us how much we can rely on technology to deliver the same uh, value of care to our patients. So, things that I do now on the day to day. Sometimes my patient calls me. They have an acute issue, or not even. They had an appointment, they couldn't make it. Okay, no worries. You're calling me now. Let me call you through FaceTime. I'm gonna call you through FaceTime, WhatsApp video, any sort of video capabilities that they may have, and let's do the visit. Let's go over that medication that you're missing. One of the most important things about patient care, especially the patient population that we care for, is that many times they may be running out of medication. They don't realize it. They really need the doctor to go over those meds. That's one of the issues. Polypharmacy. That's another issue that comes with the patients that we see. We use that video capability to get in touch and rescue more seniors just through video and go over the medications that they're taking, whether it's over the counter, whether it's medications prescribed by a PCP. You're going to see how much you can help them by reducing the polypharmacy, by going over the medications that they should and should not be taking. Going over when was the last time they saw a physician? 65 years old, I see them walking into my clinic. The last time they saw a doctor was when they were kids.
Wow.
Pediatricians. That's something that needs to be fixed. Even in my own family, I have friends of the family. I'm becoming the doctor for them. You
Right.
should be seeing a PCP at least, at the very least, every 6 months. Get your
Right.
blood work. Preventive medicine, get a blood work check, get a physical, get your vaccines.
Hmm.
You need to have access to a doctor. You need to be there. So practical issues, communication, communication, communication.
Hmm.
Proper primary care. I cannot stress enough. You have a
Hmm.
good primary care doctor, you really have everything that you need. Let me just give you a quick example. It's an uncle. My uncle, he's an elderly person. He lives in West Palm Beach.
Hmm.
He is very sick and he's seen 7 specialists. But
Wow.
his
Hmm.
primary care doctor doesn't solve any of his problems. Now, that is
Right.
the problem. That to me was the biggest red flag. So I told him,
Hmm.
you need to come to us. We need to help you. Because I've seen patients that are coming from the community with 7A specialists. When I sit down with them and I start trimming that down, their health improves dramatically.
Right.
It's like from day to night. So I mean, tactics is just being a doctor, communicating, talking to your patient, showing them that you can work with them and you will figure out what's wrong with them. But most importantly, that they know that whatever you do in their is in their best interest.
Right.
Vaccinations, blood work, and physical. It's
Hmm.
going down to the core values, right? What
That's
is
right.
the
Right.
doctor? Using your stethoscope, giving your vaccines, doing your labs, listening. I,
Hmm.
I hope that answers your question.
It does. It does. And what I'm hearing from this, and what I hear from Faisal all the time, is trust, building trust with your patients. And
Hmm.
it sounds silly, I think, to a lot of people, where it's like, what do you guys do? You must have these, great technologies. You must have these great models. You must do all this great care. And it's like, I sit there and listen to my patient, and my patient trusts me, and I can remove all these specialists that don't coordinate care, that might write a prescription and send the patient on their way, where you're sitting there and listening and addressing those health concerns that are more holistic than just writing a prescription in 15 minutes and sending them home.
That's
So
That
right.
is,
yeah.
yeah. You know what I use now with COVID? I can't do it as much, but I do it virtually. A hug.
Mhm.
So my patients used to come in, and before each visit, I would just hug them really tight. You know how they left healed. All I
Mhm.
did was hug them, listening to them and hug them. But that
Mhm.
hug healed them a lot more than anything else I did.
Mhm.
So now with COVID, I tell them virtual hug, a lot of kisses, baby pictures, but hey, that heals them too.
Mhm. Mhm. Excellent. Basil, do you have any final tips and tricks for, and I think maybe what might be helpful is to say, in addition to what you do to onboard new physicians, but like, when you think about fostering and maintaining this culture of prevention, and this culture that you have, what things do you do that people might not think of? I mean, sometimes it's easy to get into the rut of work. It's easy to just get into the schedule. How do
Yeah.
you foster this culture?
Well, the first step is you have to get into the right mindset. So let's say I'm a new doctor. If I decide to like, hey, I'm going to go into one of our new cities, Houston, for example, I will go in with the mindset knowing that there's going to be a lot of chief complaints out there. I'm going to have a couple hundred patients come on board, and they're going to have a bunch of chief complaints with a bunch of immediate issues that need to be resolved. So number one, I need to stabilize the situation. And there's a reason why such a huge percent of emergency room visits are fast tracked, because you can actually stabilize patients and their problems pretty quickly. So the first step is to stabilize and show the patient that, hey, yeah, not only do I know the pathophysiology, but I want to help you here. I want to be your friend. I want to be your coach. I want to get you back towards better health. I want to
Mhm.
improve your quality of life, your lifestyle. And so when you have that right mindset from the beginning, that I'm going to stabilize, which is quick, pretty quick, then you can get into all the interventions that'll prevent any exacerbations of whatever's going on with with that individual patient.
Right.
So it's that one-on-one. And but remember also, for anyone who's listening deep in the fee-for-service world, just to do a simple procedure when you're dealing with a model that is transactional, to do something quick like a simple steroid injection can require filling out forms of paperwork, so many forms of paperwork. Whereas when the incentive is to just improve health, then you just do what you have to do to improve the health. You're not
Mhm.
you're not concerned about dealing with all the bureaucracy of this complicated system. So it's that
Right.
mindset. You got to shift in that mindset. You stabilize, and then you can focus. You show how good you are at intervening. You show that you're accessible, and then you show that you have a genuine interest at being a health coach to improve quality of life, and beautiful
Right.
things will happen.
Yeah,
Wow.
the if I can add something to that, as a physician, when you see the outcomes, when you see your patients doing better, when you see that you're improving their quality of lives, that reinforces your that mindset, that culture of I'm here to prevent, not to just treat a disease, to prevent and keep my patient happy, healthy, and at home.
Mhm.
And and I just saw the message from Dr. Dan. It sounds very, very simple, but it's not easy. It's
Right.
not easy when you're going up against all the issues that we have in society, especially in the neighborhoods and the communities that we exist in. See, we go in the most underserved communities in every city. We're going into Houston, we're going to be going into the most underserved neighborhoods in Houston because we have a culture, a philosophy of, hey, where there is the greatest need is our greatest opportunity.
Right.
So that is also another major mindset shift. If you
Yeah.
had this concierge type of model, you would expect that ChenMed is going into the neighborhoods where the country clubs are, not where the community health centers are.
Right. Right. Excellent. Well, I think we've had a great discussion today about kind of the culture and the softer side of prevention, and also some of the sort of more conceptual areas that you can think of as you're moving forward to try and foster more preventive activities. And I think we've learned from the best about how to build those patient relationships that allow them to do so. Faisel, do we have anything else we want to cover today?
Well, Dr. Vilches, thank you so much for taking time out of your busy day to join us and talk about this culture, trying to make this shift from a reactive culture to a culture of prevention.
No, thank you for having me. I've enjoyed this discussion very much. And I'm a pioneer for improving the healthcare in America. So if you need me, I'm here.
And Dr. Dan, thank you so much for manning the chat and helping keep the conversation moving forward as always.
Absolutely. It's always great to be with you all.
And to anyone who joined us live, thank you for joining us. For more information about today's topic and to explore opportunities with ChenMed, please visit chenmed.com. We believe healthcare is a right, not a privilege.